amount of carbohydrate or glucose, that might be challenging. So we're going to cover diabetes now. It's really a disorder, and I'm going to try to talk a little faster this segment, because if you notice, I only have an hour. So if I talk too fast, raise your hand, slow me down, yell, whatever. Okay, so diabetes primarily is a carbohydrate disorder. They couldn't metabolize it, one reason or another. Two main types, type 1, type 2. Type 1 is that they lack the cells to make insulin altogether. They don't have enough, or they don't have any pancreatic beta cell because their body somehow destroyed it. For whatever reason, they don't have any beta cell to produce insulin. Type 2 is almost like an acquired diabetes, if you will. It's called type 2 diabetes. It's pretty prevalent in this country. It's the insulin is being there's a resistance, and the muscle cannot use it, or the insulin's not being secreted enough. In this country, this is the diabetes is the 7th leading cause of death in this country. And then in year of 2014, there are about not quite 30 million people being affected. And then a lot of people having pre-diabetes. I'm not sure if you heard of that term. Pre-diabetes means that not fully having the diabetes, but it's approaching that point, and the goal is now defined by hemoglobin A1C. Have you heard of that? Okay, hemoglobin A1C is very important. 6.5 is the magic cutoff. However, pre-diabetes is 5.7 to 6.4. So anytime they hit above 6 is not a good idea. What happens is when they have too much intake of carbohydrate, glucose, more than what the system can handle, that is pre-diabetes. And if they don't do anything about it by exercising, modifying their diet, or something, if they don't do something, up to 30% of the people will become full-fledged type 2 diabetic. So what can we do?
What was the A1C cutoff for pre-diabetes?
Pre-diabetes is 5.7 to 6.4. But anytime some doctor's office look at anything beyond 6 is a red flag. So depending on who's the physician you work with, some are more stringent than others, but in the book is 5.7 to 6.4. Anything beyond 5.7 is considered pre-diabetic. That means they're more prone to having diabetes later on in life. So insulin is one of the main staple, especially for type 1. For those who have no insulin in the body, they cannot produce any. They have to have insulin. So they need that on board. It stimulates, it works with the glucose. And then what it does, the second point basically, it stimulates the muscle uptake of all that glucose and make it useful instead of sitting around in the blood. And then therapeutic use is required. It's a must for type 1. It comes in a pump. It can be subcutaneous. They try the inhalation format. I'm not sure if you heard of the inhale form, but it's not quite 100% successful. So you might see that, but by all means it's required for type 1 diabetes. Type 2, you have other options. Because they do produce it, it's just that muscle is not responding to it because of the resistance. Now, insulin, it comes in many different forms, and it comes in natural or engineered. It's either from a natural form or engineered form. So natural form is of these insulin, the regular insulins or modified Lispro, Aspart, Humalog, Novolog, NPH. NPH stands for neutral protamine hexadone. You know that, you wow all your colleagues at work or other places. Nobody cares what NPH stands for, but it's NPH. Lente, now don't get that confused. Lente and something, let's see, where's that lente? Glargine. Glargine, brand name is Lantus. They are not the same thing. I'm sorry for not putting the brand name. Brand name is Lantus for Glargine. Lente is a different thing, and we'll cover that in next 2 slides. Lente comes in semi-lente. Nobody really uses that. It's either lente or ultra lente. Glargine is almost like a continuous, think of it as an extended release form. Glargine it continuously relieves that insulin effect in the body. Brand name Lantus. Sources, it comes in the porcine format or from bovine. They're not human form, and it comes in recombinant, which is the engineered form from a human source. It comes in different concentrations, so be careful when you have your insulin vial or pen in your hand. Do look at the concentration. It makes a world of difference for your patients. Generally, the order will be to say give so many units subcutaneously to your patient. But because of the concentration, it will affect how many mLs you draw up. So be very, very careful when you handle insulin. Doesn't matter which one. Any insulin, double check the vial or the pen that you have, because it comes in 100 units per ml and 500. Most of the time, oftentimes it comes in 100 units per ml. So this is a chart to compare different forms of insulin. It comes in a pretty rapid form called regular insulin. It works within the hour. It peaks out around 5 hours. It lasts for your shift. So that's how I remember. R for regular insulin, it lasts for just about the length of your shift. Intermediate, which is NPH, it doesn't kick in till after an hour, but it lasts all day. It peaks around midday. Okay. Ultra lente, for those generally, take it at home, you don't generally see that at the hospital. Ultra lente doesn't even start working till almost end of your shift and lasts for more than a day. Okay, so these are the older format that we use. NPH still being used quite a bit, and so is the regular. But the ultra lente or the lente, most of the time patients are being controlled at home. Their glucose being controlled at home with these. So that's the older agents. Now we have the newer agents. These are a little bit better. The reason I say that is when you have someone whose glucose just go up and down all the time and it's hard to control, these are far better. The first one is called Aspart. Novolog is the brand name. It starts working within 15 minutes, so it's pretty fast. And it lasts for a few hours and lasts for half of your shift. Lispro is very, very similar to Novolog. They are almost the same. It doesn't kick in. It takes a little longer to kick in, like half an hour, but it lasts just about the same amount of time, half of your shift. Versus Glargine, Lantus. Lantus is, if you would think of it as the extended release form, even though it's not, it's just the way it works. It gets up to your blood level, it gets up, and it plateaus out. It lasts like that. It doesn't peak up, go down, up and down like that. It just gets in your body, works nice and smooth all along. So it takes forever to start working, but there's no peak. It doesn't go up and down. So the blood glucose is controlled a little bit better. And it lasts all day. So Lantus is great generally at the hospital. They give it at nighttime, just once at night. And it depends on their need, would be 20 units or so at night, because then it lasts all day. For those who still have hard time during the day, you might see them give one more dose during the day. But Lantus is beautiful because it's only once a day insulin, oftentimes. And Novolog, Humalog, we use that for the sliding scale a lot. Are you guys familiar with sliding scales? They're great because it depends on how much the patient can eat and whether they are NPO. If they eat more, you can give more, and it works pretty much right away, which is beautiful, and it lasts half of your shift, so it works nicely for the patient at the hospital. Question?
Does the aspart or Lispro spike up?
Yeah, they do. Whenever you see peak, that means it's when it spike up. That's how long it takes to get to the peak, get to that spike, and then it will come down. Yeah, and it lasts for that much time. So these are very, very short acting, shorter than regular insulin. And Lantus is long lasting, much longer than NPH. Question in the back.
When would you use the aspart versus the Lispro? Like,
Oh,
what are the benefits?
Right, they have almost the same, they're almost identical. It depends on your hospital or your institution's formulary. So it depends on what your hospital carries. Like for us right now, we only have Humalog because they work so similar. It is kind of silly to carry both items on board. Good question. So on to the next. The main thing with insulin, because it has that peak, well, other than Glargine, other than Lantus, it goes up and down in terms of effect. So sometimes when it peaks, the patient's glucose might drop a lot. So you still have to keep an eye on the finger stick at the hospital. They do finger stick like every 4 hours or every 6 hours, depending on the patient. But it drops the glucose quite a bit. So watch them for these side effects, anxiety, sweating, tremor, palpitation, nausea, foam, and confusion. Sometimes they just plain old confused because they have too much glucose or too little. So sometimes, especially in older patients, you can tell, but if they start being confused, that might be just one of the first signs. Rotate the site of injection if you give it subcutaneously, not the same place all the time, because the lipids might be distributed unevenly. Allergic reaction, because some of them come from a beef source or pork source, so the patient might be allergic to it. So watch for that. If your patient ever drop too low, the sugar drops too low at the hospital, we have the chewable tablets, we have the gel, we have different forms of giving them sugar, or just good old orange juice. So you can do that. But if they're unconscious, there's something called glucogen. Glucogen is something you can give as an injection, and it works right away. But ideally, just have them drink a glass of orange juice. That's one of the fastest way to reverse the hypoglycemia. Drug interaction, of course, anything that drops sugar level will further be a problem with insulin. We have a patient when he or she was at the nursing facility of our hospital, when we used to have the nursing facility, the skilled nurses, he was scheduled to go to a surgery, and his MAR on his profile said, give insulin, give the pill, the oral pill as well, and which we'll cover in just a minute. He was scheduled to go to surgery. The next day, the nurse did not realize that the anti-sugar, anti-diabetic meds need to be held. He gave it middle of the night, the patient's blood glucose having a full-fledged hypoglycemia, fully sweating, confused, everything. And the blood sugar was like in the 40s. So it's very important that if they have a procedure and require holding of anti-diabetic meds, we do need to follow that, because it would be harmful to the patient if they have too little of sugar on board. Also, it interacts with alcohol. Alcohol it affects the blood sugar metabolism. So that's another thing. Things that can bring up the sugar will affect insulin working too. Diuretics, the thiazide that we covered from last lecture, can raise blood sugar level. And also steroids, the glucosteroids. So if they are on prednisone, sometimes there are times that your sliding scale numbers have to keep go up, because the prednisone in itself it would break things down and breaks down the sugar and leaving the sugar molecule in the blood. So that's why steroids on board, you might need to increase the insulin dose. Next thing, certain beta blockers, especially the older agents, the propranolol that we talked about last time, can increase blood sugar level. Okay. Oh, and this is a very busy slide. So any question on insulin before we go to the oral pill? Sorry, I try to get everything in one. Okay, on to the oral pill. In the past, we only have one group. Many classes of medication had come out since. So this class, and all of them, can drop blood sugar level. So we have to be really careful. Like I said, if there's a procedure, the patient needs to withhold eating for whatever reason. Ask the doctor. If they didn't say stop this medicine, ask. You don't want to give it and they're not eating, and then middle of the night they're fully unconscious and sweating and confused and so forth. So first group of medicine are the sulfa one. They are called the sulfonylurea. It's just a big name for glipizide, glimepiride, glyburide. These are the older agents. They're pretty strong. They cause quite a bit of hypoglycemia. So if the patient have procedure, or if they have some sort of disease state require more energy, so they would use up more glucose from the body, this would definitely cause more hypoglycemia. It stimulates the release of insulin from the pancreas. So guess what happens in type 1 diabetics? They can't really use that one, or if they do, it doesn't do much, because type 1 diabetic patients, they don't have the beta cell to begin with. So that might not work. It causes GI side effect, headache, hypoglycemia. SIADH is symptoms of inappropriate antidiuretic hormone. It's a mouthful, but basically it affects fluid retention and blood pressure issues. And then the second group is called meglitinides. These are the glitinides. So if you see the ending, the glipizide, glyburide, the glinides, they are anti-diabetics. They increase the insulin release, and they have to eat within 30 minutes. It can cause headache, and it's really unusual. This group of medicines somehow tend to cause upper respiratory tract infection. So the the glinide does that. And then the next group, we have biguanides. The only one we really have on the market in U.S. is metformin. Metformin reduces the gluconeogenesis, which is the production of glucose in the liver. So metformin drops or slow down the glucose production from the liver. It can cause lactic acidosis, and that can be problematic. It can be used in combination, it can be used by itself, but if your patient ever have contrast type of procedure done, let's say they go to CT scan or some kind of scan and require a contrast, this medicine must be withheld for 48 hours. So that's, if you take away anything from this slide other than hypoglycemia, metformin, hold when there's contrast on board. You must hold it. It can cause significant acidosis and a very sick patient in the end if you don't hold it. So even after PCI, sometimes in certain PCI, percutaneous coronary intervention procedures like catheterization, sometimes they give contrast. So if the patient is diabetic and taking metformin, they should hold it for 48 hours. question.
If you're holding prior, how long does the contrast stay in the body, and would you give that tail end of where it was fully out of the body? before
Right.
you-
Yeah, so it's the tail end. So as soon as the contrast stop from the body, or even 48 hours from the end, from the very end of the procedure, that would kind of ensure it. If you're not
48
sure,
before and 48 after?
yeah, because sometimes the communication, that's why communication is so important, the handoff. Be sure you check in on your report. That's why nurse-to-nurse report is so important. Ask for when the procedure was done, ask for when the contrast was done, but when in doubt, count the end of the procedure. That way you have a little leeway. By all means, 48 hours from the end of the contrast. Okay. So the next group is alpha glucosidase inhibitor. This is an enzyme, alpha glucosidase. It helps breaks down food in the system and breaks it down to glucose. So if we block that, then there will be less sugar in the body. Basically, whatever you eat, it just blocks it from being absorbed into the bloodstream. Generic name, acarbose, precose, or miglatol glycate, they literally just block the absorption of glucose from the gut to the bloodstream. But because of that, things don't break down properly. The GI really doesn't like that. So you have more bloating and upset stomach, and patient complain of cramps. You might hear that. The next group, you might hear that on the news. I don't know if you heard of pioglitazone, actose, or rosiglitazone. It should be glitazone. That's an T missing, sorry. Avendia. The glitazones, they are anti-diabetic medication. However, they also cause heart problems. Certain study shows that there's an increase in mortality in patients who are diabetic and have heart conditions. So you might hear some lawyers' ads showing, if you ever taken Avendia, please come talk to me. We might be able to get your compensation back. So there's just some information out there, but it is a big thing because nowadays this group of medication is not used as much unless the patient's been stabilized on it. At least at our facility, we don't see as much of this out there because it does reduce the insulin resistance, but it ups the heart failure and the side effect on the heart. It also can cause hepatic dysfunction. These, from the second one on down, they're all hepatic drugs. The first group, they're more renally cleared. So for the first group of sulfa, we need to adjust for renal functions. But anyways, back to the Avendia, it can cause hepatic dysfunction and it can cause weight gain. The reason we think that it can cause heart failure because it retains a lot of fluid in the person. It can cause the heart to not pump properly and then cause weight gain in addition. Then the next group is DPP-4 inhibitors. That's another little chemical in the body that facilitates glucose being processed in the body. Generic name, setagliptin, I can't even say it. Setagliptin, so they end with gliptin. So just think of that being another anti-diabetic drugs. They end with gliptin. And brand name is Januvia and Onglyza. Januvia is the older agent. We see more of that. They increase incretin, which regulates the glucose level. If you think of incretin, it mimics the effect of insulin. It can cause headaches, sinusitis, and urinary tract infection and joint pain. So that's another group. So sometimes these medications are used in conjunction with each other or along with insulin. And the last group, I apologize for it falling off of the screen there, but it's the SGLT2 inhibitors. That's a long word for sodium glucose transporter 2 inhibitor. It just basically shuts off the mechanism that transport the glucose from the food that we ingest into the bloodstream. The brand name is Infocana and generic name is canagliflozin. So anything that ends with glyphosine is an anti-diabetic drug. It also can cause increased amount of, hang on, let me get to that page. So all these can drop the blood glucose level, so be sure you check on the blood glucose. Well, you have different types of glucometers, and make sure you have your glucometer ready at hand and have enough glucose strips available and so forth. So there are a lot of agents out there these days for diabetes. And the pill form, again, if they have a procedure requiring no eating or NPO the night before, these agents should be withheld. Questions? Because we're going to move on to infection after this. Diabetes is a big topic, but again, medication is not the first line. For, unlike type 1 diabetes, insulin will be required just because they don't have that in their body to produce. That's a different story. But for type 2 diabetes, we really encourage people to exercise, lose weight, eat less carbohydrate, less sugar, so forth. On to antimicrobial. The 3 major types of antimicrobial that we're going to cover, we have antibacterial, antiviral, and antifungal on the board. Again, I apologize for skipping that slide, but it's on the board. Feel free to copy that. So the first class of antibacterial, bacteria generally, they're either gram-positive or gram-negative. It comes in those little spore form that we call that cocci, or the lengthy form, the bacilli. For gram-positive, the main staple, we have penicillin and cephalosporin, first and second generation. They cover gram-positive pretty well. Some aminoglycoside would also cover that, but not most of the time they cover gram-negative. And then we have gram-negative aerobic aminoglycoside again, and the third generation cephalosporin. And then on the next slide, we'll have a little bit more information for you. Penicillin, anything that ends with cillin, C-I-L-L-I-N, they are penicillin. So it can be amoxicillin, can be ampicillin, nephicillin, things like that. That's a penicillin. Cephalosporin oftentimes starts with the word ceph. It would be CEF or CEPH. So it can be cefacilin, which is what we give a lot of time at the hospital for surgical procedures. That's the first generation, or cefoxitin, which is a second generation. So cephalosporin will start with the letters CEF or CEPH. Aminoglycoside, you might have heard of something called gentamicin, or gentamicin, tobramycin. Those are aminoglycoside. The third generation cephalosporin would be ceftriaxone, CEFTRIAXONE. So that's third generation. It's more for as the generation gets later and later for the cephalosporin, it covers more and more gram-negatives. And then we have microbacterium. INH, isoniazid and rifampin are the ones that covers Mycobacterium, which is not a common bug, but it's in TB. That's what causing TB. So these are bacteria. So they're different. There's one more group of antibacterial drugs. They are the broad spectrum. These are the big guns. We don't want to use it on every single person because, as you may have heard of the antibiotic resistance. So if you bring out the big gun for a small little infection, then later on the bugs can build up resistance, and we're going to go over how they build up resistance. And then you don't have the tools you need later on down the road, so you don't want that. But broad spectrum antibacterials are the ones that cover gram-positive and gram-negative. They covers almost everything except fungal infection or viral. So that's what broad spectrum means, that they cover gram-positive and gram-negative. So they are penicillin. In terms of penicillin, you have your ampicillin, and at the hospital we have something called piperacillin, the brand name Zosyn. You probably heard of that. That's a broad spectrum. Third generation cephalosporin, the one like I mentioned before is ceftriaxone, brand name Rocephin. That's a third generation, or ceftazidime, which is ceftazidime. That's also the third generation. We have tetracycline. They cover quite a bit of stuff, like your doxycycline, tetracycline. Imipenem, brand name is Primaxin. And then the next two, trimethoprim, oftentimes given with a sulfur by the name of Bactrim or Septra. That's an older agent, but it covers quite a bit of bugs.
What was that one? I'm sorry, what was the...
So when you combine trimethoprim and a sulfur called sulfamethoxazole, but long story short, trimethoprim with the sulfur is brand name Bactrim, B-A-C-T-R-I-M, or Septra, S-E-P-T-R-A. So that is another group of broad spectrum medication. And then another group that covers almost everything is your quinolone. Quinolone are the fluoxetine. You have ciprofloxacin, levofloxacin, which is Levaquin, and there's moxifloxacin. So whenever you see F-L-O-X-A-C-I-N, that ends with that, that's a quinolone, 90% of the time. So fluoxetine, it covers a lot of gram-positive, but also a lot of gram-negative bacteria. Again, I'm not talking about virus, fungal infection here. When we say broad spectrum, it's just gram-positive, gram-negative bacteria. Yes.
So the most commonly used and first choice would be ampicillin, or?
Well, actually, no, because we want to start with the most basic, simple antibiotic first. So oftentimes we start with penicillin if they're not resistant to it. So you would kind of work your way up, if you will, unless they have bad pneumonia. Then we would go to Zosyn. Ampicillin works really well for endocarditis, and it doesn't work by itself necessarily. It's combined with a aminoglycoside, which is gentamicin. So this, yes, it covers a lot, but it's used for different disease states. Yeah, thank you. Yes?
So with the
Quinolones, yes,
Okay.
fluoroquinolone.
so if someone's allergic to ciprofloxacin, would they be allergic to this whole group of meds?
Yes,
Okay.
technically. And as a matter of fact, there is quite a bit of cross-sensitivity. And I didn't quite get to cover that, but that's a great question. Anytime you have someone allergic to something in that class, they have a very high likelihood of having cross-sensitivity to the same group of medication. So penicillin is a great example, if they're allergic to penicillin, I wouldn't give them amoxicillin or ampicillin. If they have just upset stomach, that's debatable. Sometimes you will see nausea, vomiting being an allergic reaction, so that's up for debate. But if they have a full body hives, couldn't breathe, they have tachycardia on penicillin, I would avoid artemisinin for sure. And as a matter of fact, up to 10%, depending on the study that you read, some studies say only 3 to 10%, some studies said only 3% or less, cephalosporin would cross allergic to penicillin. So if you have someone allergic to the psyllins, just ask a doctor if they still want to proceed with the cephalosporin. Oftentimes they would say, oh no, we'll monitor, it's not a problem. Then you say, okay. But there is a slight chance, up to 10% of cross-sensitivity of cephalosporin, of penicillin allergic patients and having a reaction to cephalosporins. And same thing with sulfa. If they're allergic to one sulfa drug, they could most likely allergic to another sulfa drug. Now, that mainly applies to antibiotic. So if they have a sulfa medication that's not an antibiotic, it's different because the chemical structure. But long story short, if they're allergic to one sulfa and you have another sulfa drug, just ask. Sometimes some topical cream has it in the cream, and some eye drop contains sulfa. So again, if they're allergic to one, ask if they really want the next one. So thank you for bringing that up. Okay, now we're going to talk about mechanism. It's just a quick overview how these medications kill the bacteria. For the penicillin group, penicillin and cephalosporins are grouped together, called something called beta-lactam, because both penicillin and cephalosporin have that nice little benzene ring in the chemical structure. But basically, these two groups of medications are called beta-lactams. Imipenem is also similar to a beta-lactam. And then vancomycin is an entity by itself. So the first group of medicine, these four, they break down the cell wall, and the bacteria won't be able to build up the cell wall, so they will die. Then a second group of medicine, something called amphotericin, is an old antifungal, but basically it breaks down the cell membrane. And aminoglycoside, the gentamicin, tobramycin, and mercaptan, most likely you will see just gent and tobra. They are used for gram-negatives, and they would stop the protein synthesis in a bacteria. And they work mainly for gram-negative. And one thing important